Hi, everyone. Good morning. Welcome to the live stream today, where we're going to be discussing the product Vyzulta. I'm very excited to be here together with Dr. Mark Blumenstein. Mark, would you like to introduce yourself real quick?
I would love to. Thanks, Billy. Coming to you from the Lane here in Scottsdale, Arizona, at the Schwartz Laser Eye Center. Yeah, so if you hear some patients complaining where I'm at, well, we know where I'm at. So we're live.
Thank you so
What's
much. I practice myself in Los Angeles, California, in private practice. I am a glaucoma specialist. I'm probably about half glaucoma and half comprehensive, which is the perfect mix. So we're gonna get into this presentation because we have a couple of cases to run through. So starting off, this is a discussion about glaucoma management in general, and concentrating around the discussion of the product Vyzulta. So we are both speakers for BNL for this product and this event. And the contents of this event are part of the promotional slide deck. This is not for CME or CE, and everything complies with the FDA regulations. Next slide. So going through the ISI just a little bit, we're not going to dwell too much on this. Most importantly, Vyzulta is latanoprost. In addition to the latanoprost, there is a nitric oxide donating moiety. So if you're looking through the ISI, you're going to see similar things to what you've seen before in your Xalotans, your Lumigans, your Travatans, which is that all of the side effects really are associated with the prostaglandin side of the product. So you're going to have your increased pigmentation of the skin, of the iris, of the lashes, or the changes in your lashes, same as the usual prostaglandins. If you have patients with a history of uveitis, next slide, or a history of macular edema, there is potentially a risk that it could exacerbate. Whether or not this is an idiosyncratic event is TBD. And of course, like any drop bottle, if it touches the surface of the eye, it could cause an infection. And just like with all the other drops, instill at 15 minutes before contact lenses, although this is usually instilled towards the end of the day. So usually contact lenses are out, fortunately. And the adverse side effects, hyperemia, eye irritation, eye pain, and installation site pain. So no surprises here. So for the meat of that presentation, we're going to be discussing two cases. I'll start off with the first one. Mark will take the second, and then we'll just, I think, have a good discussion about interesting and salient points for each of the cases, because I think with each case, we'll learn a little bit. And glaucoma is one of those art of medicine type of diseases where, Mark, you and I would probably have different algorithms for treatment and different things that we're looking for specifically in a patient in terms of risk factors. Every time I talk to a colleague, I'm always learning something new, and I tweak my own algorithm based on just the sheer amount of osmosis I get from other individuals. So next slide.
Well, Billy, I'm actually going to lean on you. So I'm here to learn from you. So I think that osmosis is going to be kind of just one way. So we'll see.
We'll learn together. I appreciate that.
Yeah.
So case one, I'm going to read through the slide, and then we'll just chat about it. Mark, if anything jumps out, please let me know. So this is a 65-year-old white male patient, was discovered to have elevated IOP at a recent exam and is returning for the follow-up. So past ocular history, none. Family history, brother and sister are glaucoma suspects due to higher pressure. That suspect category is, I don't know, Mark, you let me know. That suspect category is kind of this catch-all for
100%.
right.
Yeah.
What do you put in your
Anytime.
suspect category?
Well, I mean, it's always interesting to me because I don't always look at IOP as like, giving me suspicion for it. It just means I just need to look more. For me, when you start seeing things like thinner corneas, or you start seeing patients that have larger cup to disc ratios, or myopia, or their race, or patients that have a history of glaucoma, those are things that are more suspicious to me.
I
What
concur.
would you say? Yeah,
All of the
I
above.
just yeah. it's weird because it's like I think, people get labeled, and it's almost kind of like, I don't know if you feel the same way, but it's like I feel like we have to peel back the layers of the labels that they've been labeled, because I'm labeled like crazy or nuts. And when people meet me, they're like, true, true. But I mean, yeah, so
I
but I
agree. I
totally
think
agree with you. Yeah.
that label gets, I think it gets slapped around pretty easily. It's a, like I said earlier, and like you said earlier, it's a catch-all. All of the things that you mentioned, I concur with. And sometimes patients just walk in the clinic and they say, "I've been told I am suspicious for glaucoma before, and take a look, and I really don't see anything."
Yeah.
And but again, they carry sometimes, rightly or wrongly, a stigma of being a glaucoma suspect.
Yeah.
So moving on here, prior treatment, none, of course. This patient is newly diagnosed, current regimen, none, and Tmax, 26, 25. Those are slightly elevated pressures. Um, and I would say
Do
that those
you,
are,
Billy, do you
please.
often do diurnal? Do you like bring patients back, to try the early morning pressures versus, afternoon pressures? Is that something
Uh,
that you find important?
I do, occasionally, but not commonly.
Yeah.
This is probably the usual practice pattern that I have for the patients who are I'm suspicious about. Let's say they're progressing and the pressures seem like they're reasonably well controlled, or for whatever reason, I need to get a really good sense of how their morning coffee is maybe affecting them more than usual. Exactly, I have
Yeah.
mine right next to me as well.
Mhm.
So for the occasional patient, I'll have them do a true diurnal where we'll have them come back 3 to 4 times, and they're able to hang out around the office or come back at least.
Yeah.
But more commonly, I'll bounce back, meaning I'll see a patient early morning and then I'll tell them to come back at a late PM visit the following time. That's a little bit more viable just for, I think, our usual clinical practice patterns. And then occasionally we do have eye care homes that I'll have patients rent out and then bring me a log of, let's say, a week's worth of pressure checks themselves. But that's more for specific individuals who are really savvy with technology, I think.
Yeah.
Yeah, yourself?
No, I more the latter. I mean, or the former. I mean, I'll have patients if I'm somewhat concerned about, the change in their pressure, I'll see them in the morning, and I do try to schedule in the afternoon. But it's the bigger issue, I think, too, is we're so busy. I mean, compliance with, just drops, just taking medications is so low. And then also with, follow-up visits, I try to streamline my appointments as much as I can.
Agreed. Me too. Me too. So moving on here to the medical history, prior medical history of hypertension with lisinopril for treatment, pretty standard. And then lastly, allergies, no known drug allergies. Next slide. So ocular exam, best corrective vision, 2025, probably some very, very early light cataracts. External exams unremarkable, pupils are fine. Slit line exam, again, very small early cataract, age appropriate. Looking at the pressures here, these pressures a little bit lower than the ones that were documented on the previous slide, 23 on the right, 24 on the left. 8:30 in the morning. Does that timing mean anything to you at all, Mark?
Well, that would, I mean, my assumption would be is that would be at the lower of the trough for their pressure. Yourself?
It's interesting. It's one of those things where there's a kind of guidance about where pressures should be higher and should be lower, right?
Hmm.
But
Yeah.
I think in reality, we see lots of patients who are who break the rules, who are
Yeah.
not following the textbook. So
Yeah.
I think the pressure is interesting and the timing is interesting. I think it's more
Yeah.
interesting to get an 8 a.m., 8:30, and then a 4:30, let's say, and then to
Yeah.
be able to see that together. Central
That's a great
corneal
point.
thickness, 510 and 490 on the thinner end of things a little bit.
Yeah. Yeah, the,
And
the average corneal thickness is about 530 microns. So it's a good reference point. You can definitely see the left eye's thinner.
agree,
It's a big
exactly
deal.
correct. And a little bit of discrepancy. We tend to see that a little bit. 20 microns, maybe a little bit more than I'm expecting for a patient with
Yeah.
virgin eyes that hasn't had any laser vision correction. And then moving down, corneal hysteresis. That's an interesting one. Corneal hysteresis is one of those measurements in glaucoma where it hasn't made its way into general care. Part of it is, as far as I'm concerned and aware, at the moment, there's only one machine that does that, made by Reichert, and not a lot of offices have access to it. My office does not. Does your office?
It's interesting. We do because as a refractive surgery center, that we were always very concerned
Yeah,
about changing the thickness of the cornea, as well as the steepness and the flatness of the cornea, and how that really enabled us to be able to measure IOP. And I've been using hysteresis for at least a decade. And I'll be honest with you, the first thing that I saw when I looked at this was the interesting fact that, anything over 11 is considered to be kind of within normal
wonderful.
range. And
Yeah,
then,
absolutely.
a little bit about 8 to 10 is, you start to worry a little bit. And anything 8 or below, I would probably, be seriously concerned. And just looking at this left eye, it's a little higher pressure.
Agree.
Microns are a little thinner in the cornea. Hysteresis is bordering on that lower part.
Agree.
My spidey sense is getting me a little nervous about what the optic nerve looks like.
I concur entirely that that right eye, as you said, with a 12, it's actually above average,
Yeah,
and it's one of those interesting things where IOP is IOP and corneal hysteresis. They're both they have actually um, similar norms in the sense that the normal range, of course, of the IOP is around 10, quote unquote, the normal range, and hysteresis is around there as well. But the lower the hysteresis, the worse, and the higher the risk of the eye for glaucoma and the ability to absorb that pressure-induced the shock effect, right? And the higher, the
yeah,
better. So that right eye as 12 seems great, and then the 9 actually was the one that kind of popped out to me, just as what is for
yeah,
you. And so looking at gonioscopy, grade 4, open angles, mild TM. Next slide.
yeah.
So what do you think? What do you think about that left nerve?
Yeah, the left eye looks like Miss Jackson. It looks nasty. You nasty. You nasty, Miss Jackson. I mean, I just, it's funny as my son, who's a first year optometry student, I am not kidding. Like this morning, just sent me a question about, you know, does the disc shrink? Does what happen? I'm like, dude, okay, you need to get your head out of your. But one of the things that we talked about was the isn't rule. He goes, oh, I learned about the isn't rule and how glaucoma doesn't follow that. And you look at that left eye, and it is a perfect example of that. And then also that peripapillary atrophy. Yeah, I'm a little dubious about that left eye, even more so now looking at the picture and looking at the data we had.
I agree. I agree. So as you called it in the previous slide, that left eye with, I think, the slightly higher pressure, the slightly thinner CCT, the slightly lower hysteresis value, you were saying that the left eye is probably going to be a little bit more concerning. I agree. I think that left eye looks a little bit more concerning on the cup to disc ratio. So next slide. But if you look at the OCT, and for a newly diagnosed patient, assuming they have been followed for a long time and seeing their eye physician on a yearly basis, then newly diagnosed, newly elevated pressures tend to look like this, right? They're
Yeah,
good.
yeah,
They're green.
yeah.
They're unremarkable. If you zoom in a little bit, which I know it might be a little challenging on this presentation currently, but I believe that the left side overall average thickness is a little bit thinner than the right, which is kind of that possible green disease stage that we sometimes speak of, where everything looks really good if you just glance at it, but then if you dig in the numbers a little bit, it may be indicative that the eye is not doing as well as it should. And if you
Right.
look at the sectoral areas, especially towards the temporal aspect in the usual suspect places, that infratemporal, supratemporal area, it's also just a little bit thinner, not quite as robust. And this is where having the opposite eye, of course, really helps to give us a threshold for what normal is in this individual.
Yeah, totally agree with you.
Next slide. What do you think about these fields?
I mean, honestly, looking at the OCTs, as suspected.
I agree.
I mean, I de-emphasize visual fields. Maybe I'm just. I mean, it's so much damage has to occur before we get to that visual field, that it's almost to me just more window dressing. I mean, I've already made up my mind just looking at the optic nerve and all the other data up to that. I'm happy that the visual field and the OCT both look relatively normal because that's our goal, right? Is to maintain patients' quality of vision. And I remember when I was younger, it was like, you want your patients to die with glaucoma and vision. You don't want them to die with glaucoma and not vision. That sounds so morbid, but so true.
Uh, as a chronic disease, without a cure, at least our goal is just to maintain, keep them
Yeah,
plateau, keep their good vision good, keep their if there's damage, then we keep everything we can. But I agree, these fields look totally normal and completely predictable based on the OCT that we saw earlier. A lot of structure has to be lost before we start to see the functional deficits. Next slide. So assessment and plan. So this patient, ocular hypertension is the diagnosis, and I agree with that, but probably pre-parametric glaucoma on the left side, and the
okay,
glaucoma suspect kind of diagnosis there. So risk
right.
factors, all of those risk factors, I think we agree with. The family history of the elevated IOP in the siblings. That sibling diagnosis of disease is really kind of a big warning sign for me, probably for you as well.
Yeah,
The distant relative, sometimes they'll bring out this huge family lineage, and then they'll say brother or sister, and I kind of peek, my ears kind of peek at that. Age, the systemic hypertension, the thin corneas, but more importantly than the thin corneas, I would say, is the low hysteresis on that left eye, and then the increased cup to disc ratio, and patient plan and discussion. So assessment calculator. So there is a great risk calculator out there for those who treat glaucoma all the time, and for those who don't treat glaucoma that much. There is a risk calculator. There's an OATS risk calculator, and if you plug in a lot of the variables that they're asking for, it will spit out this risk of disease percentage. And I don't know if you ever used that before. I have myself. It's helpful,
hmm
especially
yeah,
for those borderline cases, or again, I think for those who don't treat glaucoma as frequently. I think it may help in terms of making a judgment of whether or not a patient does get treated.
yeah,
One of the things that I sometimes hesitate on is just that earlier on in these disease cases or in those suspects, I'm a little hesitant to put a patient on treatment and commit them for life unless I'm sure that this patient is going to need it. So in this particular case, due to the high risk of the patient converting to glaucoma, Vyzulta was started with a target of about 25 to 30% IOP reduction, which is our ophthalmologic as well as our optometric guidelines, with return follow-up in 1 month. Next slide. And during the 4-week follow-up, Vyzulta was well tolerated. Patient adhered to therapy. Ocular exam is unchanged, and the tonometry is showing at a 9 o'clock, so comparable time in terms of pressure check of 15 and 17. So had that 30% reduction in pressure, and tolerating a medicine, once a day medicine, importantly as well because of compliance issues. So I
yeah.
think it's a really nice early catch, early diagnosis, and early therapy. We see Vyzulta work really well in everywhere, but really if you're catching them early, before the TM is really scarred down, you see these really robust effects.
Yeah, definitely.
Next slide.
Well, we have another case. We're running up on time here because we don't want to keep you guys too long, but we'll go through this case pretty quickly. This is a 74-year-old Asian female patient, and she has normal tension glaucoma. And one of the exciting things that we know about Vyzulta is that there was a really robust study in Japan. I believe it was the Jupiter study where they were looking at normal tension glaucoma patients. This person had mild primary open angle, diagnosed about 3 years ago. There's a little bit of myopia, but we're going to see in a few seconds here they have an optic nerve hemorrhage, a little Drans hemorrhage. Now, the interesting thing too is that she said she's allergic to brimonidine, and Billy, have you ever seen anybody really truly allergic, or is it just more a sensitivity? I mean, the allergy thing is so narrow.
Um, at this time, I've heard patients tell me that they're allergic to everything and anything.
Yeah, exactly.
Um,
I mean, I'm allergic to work, but I still come in. It's just it's a sensitivity to the people I'm with.
it's a
So,
sensitivity
but
tour.
yeah, yeah. So I take that with a grain of salt. But the redness, the irritation the patients have, they don't want to be on it. So their previous treatment was latanoprost and generic brimonidine, which I also think is somewhat disconcerting because I do everything I can to keep my patients on a branded medication. Currently, they're taking latanoprost, which is obviously a generic. Now, the maximum, her Tmax was basically 21 millimeters in both eyes, which is, I would absolutely categorize that as a normal tension glaucoma patient. Low blood pressure, she's on some Synthroid and vitamin D. And of course, we know she has an allergy to brimonidine, but I think that's just there for us to think of something different. Next slide. So her best corrected vision is 20/20, which is fantastic. Um, Everything is pretty unremarkable, with the exception that currently on Xalatan, her pressure is 18. We see that her corneal thickness is a little bit about one standard deviation thicker than average, and her gonio angle is open. So nothing here, nothing to see. I mean, we're right at this.
Typical, I agree.
Yeah, right at this moment, you probably like me, Billy, are thinking, okay, you're on Xalatan, living the dream, things are good. Let's go to the next slide, though. It's almost the exact opposite of the last patient we saw, right? Zero point 0.6 cup to disc with some vertical thinning in the right eye versus a zero point 0.4 in the left eye. But to me, the minute I see a hemorrhage, it's like, again, there's that just light in the back of that goes off in my brain that basically says we're not at a place where you should feel comfortable, Mark. We need to lower the pressure. What does a Drance hemorrhage mean to you?
Trans hemorrhages are they're tricky. I think they're a really good.
Tricky.
Um, I think it's a good indicator that this patient, if they're suspicious for a disease, especially normal tension disease, it's going to send signals and warning signs that this is probably true disease and that's something that needs to be monitored closely. It's one of those situations where we don't know exactly the actual relevance of the trans hemorrhage in terms of
Mhm.
if it is coming before disease or it's a after effect of lost tissue already, but certainly one of those indicators that this is an eye that needs to be watched very closely, if not lowered a little bit more possibly.
Well, let's look at the OCT. Let's go to that next slide. So now, knowing that we have a Drance hemorrhage on that right eye, we have a little vertical inferior thinning. What does this OCT tell you?
I think it matches up pretty well with the disc photo earlier. The
Yeah.
areas of thinning are what we would expect based on the thinning we saw on the clinical exam, with the right eye being the one of concern a little bit more, and the left eye being relatively robust still.
Yeah, totally agree. Let's go to the next slide. And we can look here at the visual field. And, I don't get too worked up when I see that there's peripapillary atrophy and we see a little bit of a paramacular um, defect, especially as we can see there in the left eye. And is there anything on the visual field that gives you concern?
Not specifically. Also fairly expected fields, which is
Yeah.
kind of the large blind spot, which is one of those early indicators or early field defects that we see in glaucoma patients. Oftentimes, I think the one thing that popped out to me with these specific fields is that the right eye was the one that had more of the cupping as well as the nerve fiber loss, and the right eye
Right.
was pretty darn good. And the left eye
Yeah.
actually didn't seem like it would have. I was predicting no field defect actually in that left eye.
Yeah.
There's a slightly larger and large blind spot,
Right.
which is
I
interesting.
think I yeah, I think that's from the peripapillary atrophy if I was gonna be guessing on that because I mean they're a myope, right? Next slide, please. They have systemic hypotension, that disc hemorrhage. We talked earlier in this feed about what are the risk factors, and we've got some of them right there. and obviously that newly noted disc hemorrhage with that vertical thinning, we need to give this person an opportunity to reduce that pressure a little more. And we saw, significant improvement when you compared Zalatan to Vyzulta. We got about another 30-40% drop. So, let's switch them from generic latanoprost to Vyzulta, and let's see what that does for them in about 4 to 6 weeks. Next slide. And we definitely see that there was about a 25% reduction in the pressure. So that makes me feel comfortable. I feel happy about that. You feel happy, Billy?
Good response. I think the changeover from the first half, the latanoprost portion of the medicine, to something with nitric oxide dominating moiety helps gap those patients where the nitric oxide component is the part that they're really needing. I think it was during the dose ranging study of the Voyager trial, where they were checking for the number of patients who had differing levels of pressure improvement. And they saw a good 40% of patients had at least a 2-point response, and 30% of patients had a 3-point response, changing over from branded Zalatan over to Vyzulta. And so keeping it at a single agent and using something that's a little bit stronger can very effectively bring a patient down to a goal level of pressure.
Yeah. I mean, it's one drop that basically gives 2 mechanisms of action. I mean, and we already mentioned before about compliance. So it really is a phenomenal opportunity to help lower your patient's pressure just in, one bottle. So next slide. So as we mentioned before, Vyzulta is latanoprostene bunide ophthalmic, and it's indicated for patients with open-angle glaucoma. We talked a little bit about that safety before too, the increased pigmentation, gradual changes to eyelashes, which is not really a problem. Moreover, caution your patients with a history of ocular inflammation. Next slide. And lastly, we worry about a little bit about some of the other side effects that we talked about, or risk factors. There's very little side effects. I mean, less than 1%. So contact lenses should be removed. And our last slide is basically you and I saying thank you to everybody for joining us. Billy, I picked up a few pearls. Got to get
Mark,
some coffee. And
always fun.
Yeah,
really enjoyed the time. Thanks for sharing this presentation.
Thanks everybody for joining us.